So here I think that we can distinguish between autologous stem cell transplantation and allogenic transplantation. Now with the arrival of anti-CD19 CAR T cells in second line of therapy, the role of autologous stem cell transplantation has decreased. Also because in this setting, the CAR T cells were approved especially for patients refractory to chemotherapy. So autologous stem cell transplantation is basically high-dose chemotherapy. Ideally, it would not make sense to offer an autologous stem cell transplantation after failure of CAR T cell in second line because the patient was chemorefractory. But you know, the role and efficacy of stem cell transplantation is depending on the response that you are reaching with a previous therapy. So it is possible also that in the future, with newer second line chemo or immunochemotherapies, possibly the role of autologous stem cell transplantation could be taken into consideration also in the future. I don't know, but this is a very interesting question for the future. While allogenic transplantation, as we show and from other reports also at this meeting, the EBMT 2025, is still a strategy that we should consider for a patient relapsing after CAR T cell therapy, especially if you can re-induce a response, partial or complete response with newer therapies. So in that sense, I think that today maybe allogenic transplant also it has diminished, I mean in terms of numbers, but it still has a clear role for large B-cell lymphoma. I cannot say the same thing for autologous transplantation, especially for high-risk patients, those who have received CAR T cell in second line of therapy, where possibly such a strategy is not considered in the salvage therapy consolidation, because most of them are refractory patients. But newer studies are needed in the future. Maybe as observed in Non-Hodgkin lymphoma, we can delay the use of autologous transplantation, not in second line, but maybe in further line of therapy if a response is achieved.